One of the ways that we could potentially identify patients that are cured is to identify some marker of MRD, or minimal residual disease. Now, currently, a lot of the trials are looking at things like circulating tumor DNA. And essentially what that means is we're looking at very low levels of mutated DNA that is coming from the tumor. We're doing that by looking at very low levels of DNA that's circulating within the blood, outside of the cellular compartment, as well as within cells, like, for example, in circulating white cells. And the very early results right now look very promising, actually. There were trials that were done at the NIH and at Stanford that suggested that using things like circulating tumor DNA, we could monitor patients and actually predict relapse before they developed a clinical relapse. In other words, we began to see the emergence of the malignant clone way up to 6 months or longer before their CAT scans or PET scans became positive. So it's very encouraging. Hopefully in the future, and we're already starting to see this in studies, for example, with CLL, if we can determine a validated marker for minimal residual disease in large cell lymphoma, mantle cell lymphoma, follicular lymphoma, we could intervene. And ideally, for example, what we're seeing in CLL, we could know how long a patient should continue on therapy. Potentially, we could stratify patients into different groups. Some patients may need more aggressive therapy, some patients less aggressive therapy, as well as expose patients to novel or alternate regimens if they're not responding to therapy based upon their MRD status. And I'll give you a kind of a case. If a patient has a given tumor, and I'll just say large cell lymphoma, and they become MRD negative after, for example, 2 or 3 or 4 cycles of therapy, we can potentially stop treatment early. And then let's flip that. If we have a patient who is still MRD positive after 3, 4, 5, or 6 cycles, this is the patient we might want to intervene early with something like autologous transplant, CAR T-cell therapy, or some other novel targeted drug. So in the future, I see if we can identify good markers of MRD in different types of lymphoma, we could use that really in 3 main ways: to modify induction therapy so we can get the deepest response in patients. Number 2, we could potentially identify patients that are cured very early in therapy and therefore maybe monitor them differently. And in patients who we're following over the long term, we could use MRD as a surrogate, but so we could essentially get rid of imaging studies and therefore expose patients to less radiation as they go through surveillance.